Thank you so much, Jay. Thank you so much, everyone, for joining. Those who've registered and showed interest and also taken out the time to hear us out and also potentially collaborate with us based on whatever it is that we'll share over the next 30 to 40 minutes. So I'll just straight away jump in. Prior to the Ayushman Bharat digital mission, the health system in the entire country was operating in silos, wherein wherever there was a public or a private sector a solution that was deployed, whether it's in a public health facility or in a private facility across the board, there were some health records that we were seeing being created in a digital format, but they were not linked, and there was no overarching or umbrella view of the beneficiary or the citizen's entire health history and an entire health case scenario. That will lead to a lot of challenges, which included affecting the quality of care that was delivered to the patient because a lot of their history or past treatment was lost and led to a lot of extra expenditure, duplicate data, the patient having to go to multiple touch points and then starting all over again in terms of whatever treatment or even sharing of data that they had to do. And at a larger macro level, made monitoring of treatment adherence also quite slow, where policymakers, as well as even the specific facilities and solution providers, could not actually track the patient's health history, of course, with consent. So, what the Ayushman Bharat Health Account, which is a digital public registry under the Ayushman Bharat Digital Mission, did was essentially function as a unique health ID and identifier for every patient or citizen receiving care. This also became an identifier that was mapped and linked to any point of care across a digital solution. So, even if there were unique identifiers created at a platform level or at a facility level, those could be linked to a larger identity for the patient, like Aadhaar in a certain sense. Abha was the digital public good for the patient identifier in the country, and that allowed for a more longitudinal view of the beneficiary's health. So, no matter where they got treatment, whether it was public sector focused or in a private facility, overall, their health records could be linked to the ABHA and their health history could be tracked, maintained, also improve the diagnosis, reduce the time of diagnosis, improve the efficacy of care that was delivered. Just sort of zooming out now and taking a step back, what the Ayushman Bharat Digital Mission intends to do with its larger vision is work towards universal health coverage and create a overarching national health digital ecosystem. Um, it also tries to create an infrastructure that is truly open and interoperable, right? And creating a standards based digital system, of course, leveraging FHIR. International Patient Summary is also one of those standards that we're now working towards. The idea is to ensure security, confidentiality, privacy, ensure inclusivity, enhance accessibility, increase affordability, and make an efficient ecosystem which is also safe and secure in terms of data management, with an aim to ensure timely precision care. So ABDM is the technological backbone that is necessary for the country to enable this digital health infrastructure in practice. And what it does is it also creates a highway or a digital road across the multiple stakeholders delivering and also seeking healthcare. I'll explain further how that happens. So this slide essentially shows the entire technology stack, that is the entire digital health infrastructure that ABDM creates, and also the way it functions, because we felt that it was important for the participants to understand how the technical stack is designed, keeping the principles that I just shared in mind. So, given that it is a digital public infrastructure, I would encourage everyone on this call to focus on the bottom of the slide. ABDM not only creates digital health registries that are specific to health, including the Ayushman Bharat health account, which is the unique identifier for patients that I started off with, a unique identifier for health professionals, a unique identifier for facilities and drugs, but it also leverages some cross-domain digital public infrastructure like Aadhaar, which is for identity, being widely used in the country, UPI for payments, etc. So the entire technical infrastructure, that is the three main blocks on top of this, in the middle layer, in fact, leverage these registries that you see at the bottom. So Abha ends up being the identifier, that is the common identifier for a citizen, no matter what gateway that they may be trying to access or trying to leverage in their interaction with ABTM. So, what this means is there are three gateways. One is centered around health services, which is the unified health interface. One is centered around health data management, sharing, and consent. And one is centered around insurance claim standardization and settlement. Although the layer that you see at the top of this is essentially all the private sector applications as well as public sector platforms and applications that are in fact just plugging into this system or in every any gateway or maybe even more than one gateway to deliver specific functionalities or transactions to the seeker of care as well as the provider of care. So just to take a small example, if I am a patient who has a Abha number, which is a unique identifier, and I want to um, conduct a doctor consultation or a teleconsultation with a doctor which is registered on UHI would end up using an end user application, which is my patient facing application, which is enabled by ABDM. It is ABDM enabled to look at all the health providers that are available on UHI through, again, a very similar integration. So all the provider applications will also plug into this network and this gateway and be visible to the patient. The patient gets a wider choice of verified providers, and they're able to, at just a single click of a button, view them as well as proceed with a booking and an appointment henceforth after that. This is an example of one transaction that can be conducted through and facilitated by the Unified Health Interface Gateway. But similarly, similar transactions can be done through the HICM Gateway for data exchange and NHCX, which is for insurance. So moving on, through this entire technical infrastructure, what ABDM is trying to do is to actually allow the different stakeholders and actors in the healthcare ecosystem to interact with each other. So just like the example I gave before, citizens can check the availability of all types of medical resources, information, blood banks, anything else, doctor consultations, ambulances in future, discover what kind of services and products they want to access, book them, avail them. What providers can do is see the patient's health history linked to their ABHA as a unique identifier, provide all their digital health consultations and become discoverable to other players. Similarly, insurance players can settle claims across payers and providers. Policymakers can have a macro overarching view of all types of transactions that may be happening in a country in a de-identified anonymized format, which allows them to also better plan for public health emergencies and figure out better programs, better policies that can service the current population needs, including disease burden and such like things, and other infrastructural capacity challenges. So moving on to how ABDM has been doing so far, you can see the snapshot here of the different registries that I just spoke about for health, data, and insurance. But I would actually like to focus on just two of these statistics, which we are sort of trying to discuss through the International Patient Summary as well, is of health record creation and the amount of health records that have been digitized, linked to a patient's ABHA, and also maybe recorded in a digital format somewhere in the health ecosystem, right? So for 868 million plus citizens, Ayushman Bharat Health Account, which is a unique identifier, has been created in the country. And to those specific registry identifiers, around 932 million plus health records have been linked in the present day, and this number continues to grow. So, of course, there is a lot of data that is being created in a digital format and is now going to slowly start coming into use in the next, over the next year, and of course, over the next couple of years, as digitization also continues to grow in the country across the private sector as well as the public sector, right? And currently, how ABDM ends up enabling this through the HICM gateway, just double clicking on that, is that if an HMIS or LMIS solution is plugged into the gateway, any other hospital or clinic, which is also using an HMIS, LMIS solution, or even a program software, can link, share data across. If it was not clear, just wanted to double click on this with the patient's consent. So if the data belongs to me as a patient, I can give consent for any transfers that are happening across hospitals, diagnostic centers, clinics, any other such relevant entities which have probably created a digital record for the patient, with ABHA being used to uniquely identify the patient and HFR, Health Facility Registry ID, being used to uniquely identify the facility across this entire universe. So for a patient, the benefit is that they don't actually need to manage multiple apps for storing health records, for giving consent, for viewing which providers are available to them. Given that there is patient consent and they're able to manage that consent and exchange as well, right? So coming back to the point of the large amount of data that is actually being generated through ABDM and through the HICM gateway and just digitization in the country, um, I think the next challenge for us, or the next problem statement for us at a national level, also becomes the need for usable health records or the longitudinal health history actually being efficiently consumed when it's relevant to be consumed, right? So once these digital health records are created in real scenarios with respect to emergency, travel, even just regular diagnostic, sessions or consultations with the doctor, are they actually being used? And if at all, how can we improve their efficient consumption at that point of care? So this is where actually IPS comes in. This is one of the challenges that we were thinking about at a central national level as to how to actually start working on the next step forward and make these records a lot more usable. And the referring to the previous slide that I showed you of how there is a little bit of dependency of on the HMIS initiated or HMIS or LMIS software providers who actually may be creating the digital health record to maybe share them with another player, or there is a federated system in place, so there is a little bit of dependency on an other entity to actually initiate or provide this information in the face of an emergency, which could lead to delays, which could lead to inavailability of the data in real time, right? So we this also became one of the gaps that we wanted to think about, that how do we create a summary or summarized view of this health information, which is not only usable, which makes the longitudinal health history a lot more relevant at the point of care. And it also reduces the real time dependency on a lot of HMIS players or other entities which are involved. Um, Further, I think we wanted to also ensure that it's a standardized system that we're trying to create. So while FHIR already exists, and I'm sure some of the audience members here would be aware of this as a standardized format for data exchange and interstate cross-border exchange, patient data could still remain siloed. So in the real-time scenario of actually trying to access health records, if there is a system that may not respond in time, the format itself, though standardized, may not help us. So what we wanted to do was also, while we're creating summaries of information, we want to make sure that not every player is not creating a summary in a different format. And we wanted to take a very active, proactive step towards this to ensure that we're working with the National Resource Center for Standards in India, and we're basically putting together an Indian patient summary standard, which draws on the FHIR structure, but again is a step forward in that direction. So actually, now coming to international patient summary, I just thought that that context was very important and critical for people to actually be aware of. So what the international patient summary is, it's a standardized and minimal, non-exhaustive set of clinical data, right? And I've already covered that it's supposed to ensure continuity of care. It again is defined by the HL7, but it's been adopted, sort of adapted to the Indian context. We're keeping in mind what is the real use cases and what are the ABDM rails that are already in place. It's adapted to make it a lot more usable on ground, because we want the standard to actually be to see a lot of significant adoption, and we believe that it would make a very real difference in time critical situations. So it would have an international format baseline, but maybe we've also included certain specific parameters which my colleague will go into and explain in detail in terms of like social history and other such parameters. But it would still provide the minimum data set. So the idea is that the entire structure is standardized in a manner that, based on the use case, different sections could be populated and still make it usable. So it's an overarching superset that could be that the parts of which could be used in different manners, depending on the use case or the situation. Like travel would use a very different format, maybe for visa purposes, and the sort of fields required might be different. But maybe in an emergency situation, you might need some other additional parameters that are mentioned, right? So we've tried to create it in a very exhaustive manner. Um, and the idea is that it could be India's emergency and referral grade health passport. That's the analogy that we would like to generally use. So, just to also give a quick view into how IPS is actually being used internationally across use cases and what could the power really be, we saw that in Malaysia, about 31,000 Hajj pilgrims traveling to Saudi Arabia were actually able to use this IPS format to sort of store their digital smart health certificate in a certain sense, which could include maybe their COVID vaccination status, any such basic vitals, allergies, blood group, and other information that could help prevent emergencies in an other country. So this was used at this is a real example of how IPS was used in that particular scenario, and it actually, given the volume of pilgrims, this was useful. What Brazil is doing is slightly different. They are actually trying to create the IPS and embed it more, make sure that every citizen, in fact, has an IPS that is created, right? And it's more done at their national digital infrastructure level itself. And this is something that they've been working on for a while, and it also ensures that whether a patient, irrespective of where the patient goes, there is some sort of continuity inside Brazil itself. What EU is doing, European Union is doing, is that they have ensured sort of interoperability across the EU member countries, right? So whether they travel within the EU, they're able to actually consistently have their core health data available and stored, and the treatment is a lot quicker, right? So these are just some quick examples. What we are actually now focusing on in terms of use cases are some practical applications that we sort of see within India, which we wanted to start off with. And of course, there are many more, but some include a scheduled surgery or routine doctor consultation, which is the most basic one where this could actually become useful, wherein the doctor just wants to see a quick snapshot of vitals, allergies, past surgeries, any important relevant information about the case history, any emergency or unscheduled medical situation, and that could be in a foreign place, could be a state or another country as well. Interstate or cross-border travel and related medical certificates could be also in a summarized format where IPS could become a lot very valuable. And it could also be for chronic disease care, right? Where there's a large amount of health information and you want to make it concise, usable, and important for a patient who may travel or anything in that similar format, or even going to a different specialist in across in the same city or somewhere else. And the other application is administrative reporting data analysis at a more macro level and a de-identified manner, where governments, where larger organizations, including private sector, with consent in an anonymized manner, are able to actually figure out some insights about the disease load, the kind of care, administrative insights, etc. So the way in which we have currently sort of identified these applications is again stuff things that we think that will be prioritized by the National Health Authority at the current time, and these are some of the scenarios that we want to definitely solve for and prioritize. And there are two ways in which, or two modalities through which these use cases can actually be facilitated through IPS, right? So it could be that the personal health applications that the patients are using and have control over from where they provide consent are actually able to create those INPS records, international Indian patient summary records, for a selected time period. Or it could be that the point where the health records are digitized and created, which could be any health solution um, used by a facility, hospital, lab, HMIS, LMIS, right? Those solutions could also be creating these summarized views, right? This could be a separate sort of usage and very important one in that. Sorry. Yeah. So for now, the way we've envisioned these use cases are that the PHR or the patient-facing application is actually creating the summary, but there is enough scope and potential for any digital solution companies to actually use this health information record for multiple journeys, including the ones mentioned in this slide. So, wanted to actually cover how ABDM currently supports the IPS structure, right? So certain things which are already in place, such as the ABHA ID, right? The idea is that the unique identifier or the ABHA ID could potentially, the IPS that is generated could be linked to the ABHA and again actually become part of the longitudinal health history in a more usable format. Um, some use cases that we already have as part of ABDM, including a very instant scan and share of records, that you go to a facility, you scan their QR code and share your record instantly, eliminating the need to carry any manual documentation and printouts, etc., to the doctor. This could also have IPS be part of it because it's again a health, it's a format, and the document that you share is actually the IPS. This could also take a form in maybe an emergency situation, and we can figure out ways in which, even if the patient is not able to give consent, there are some predefined consent that they may have given, and this information could be sort of stored in a QR, etc., which can be scanned by the facility, right? This could be one example. So consent manager is again something which is the HICM that I spoke about that actually has some contours of purpose definition, time-bound sharing, which is already in place within ABDM, fire standards, which IPS already supports and is fire native, and all the health facilities that are currently linked with ABDM that are sharing records, consuming as well as sharing, can still consume IPS. So these are the ways in which IPS is already bolstered through the current ABDM infrastructure. And we've already covered to some extent how it could be better than sharing everything. So basic things like efficient, minimal, relevant information, ensuring high patient mobility through the portability that it creates. It could be, there could be a mixed digital maturity. It could be auto generated by the patient, by the solution, or it could even be clinician curated. It could be patient generated and stored in the application. Multiple languages are actually structured into coded data, and you see a lot of unstructured records in the system. And the idea is for maybe solutions to structure them and store them in this format. And of course, it makes the record history more useful and usable. So I think all the stakeholders from an ABDM standpoint can definitely benefit from the use of INPS. In our visualization and what we've envisioned, PHR applications used by the patients could be the primary IPS generators, but maybe not the only ones, right? And there could be a mix of mixed modality in which there are some patient-reported parameters, for example, blood group, which may not be always mentioned in a digital record, right? And it could be a mix with all the digital health history, such as medications, allergies, etc., that may already be stored in a digital record and picked from there. HMIS systems could generate the IPS during a discharge or from a hospital, where they could probably summarize the entire treatment of a care point of care that may have happened at a certain point of time, right? So maybe you were admitted for a surgery, and that entire all the records generated during that incident are actually summarized in the IPS structure. And again, they could also consume this information during an emergency in the emergency ward, right? HIUs are health information users. So this could be anything: emergency departments, telemedicine platforms, referral hospitals, even government programmatic care platforms, like which can work in a slightly fragmented manner, but should interact if there is overlap of benefits being provided. Diagnostics and pharmacies could also use them. Connectors, again, these could be converter applications or connector application, right? They could be built by some digital solution companies, even independent players who are digital solution companies in some sense, who are actually able to create a connector for a health specific solution to use and convert and create an IPS from that. Then there is a fire or a developer community. Maybe, there could be a lot of applications and innovations possible on top of this, leveraging this IPS structure, which could actually come out in the entire ecosystem. And that would be, we would be looking forward to those innovations as well. So actually coming to a quick user journey as to what we've envisioned primarily in the PHR context is that there is a situation that the health record, the health worker that the patient is actually going to, or the provider or the doctor requires a summary of the patient's health history for a routine consultation or a surgery. And the patient using their personal health application initiates the creation of that record. So it could already be linked to their ABHA, or they link it through the PHR application, and the PHR uses a inbuilt converter or some open source tool that they are using to create the IPS structure as per the standard that we have defined. And this record that's created, which is the summary record, gets linked to their ABHA stored. The health worker can initiate a request, or automatically the patient can do a scan and share this. The consent is also implied if it's generated by the patient, and that's built into the tech of it and the API calls that we created. And essentially, they are able to share that with the doctor, and the doctor is able to see it in real time. There could be various modalities, embedding it in a QR, and others that we can think of and the community can think of. The other flow is of an HMI system using it. So, of course, I just want to reiterate that it doesn't always have to be the case that the PHR is only the being the primary user of it. It could be any other software as well. That is, say, like already covered in a surgery scenario, that you're there for a longer period of time, and maybe you go to a specialist after that, and then you are basically using an IPS that may be created by the HMIS, previously a particular health information management information solution, and that is shared at the relevant point. So what I'll do now is actually hand over to my colleague who will take you through the specific details of what the IPS structure entails in India, and the specific INPS, what was the process that we followed to create this. Ujaswini, over to you.
Thank you so much, Devika. So what I'll briefly cover is how we created the INPS and what it basically entails in a little depth. Our process was, we tried a level best to make the process very holistic in nature, since this structure would be something that will be used by diverse situations, that will be used by diverse entity in very different contexts and scenarios, even within the country. So initially, we did start off with understanding the international structure and applications. We went through a lot of different countries. We've already used it in different situations. How do they use it? And we also did a little mapping of how those health information systems of those countries are similar or different to India's structure right now. That gave us a lot of learning as to what to do, what not to do. Moving on, since again, as I mentioned, that we are very diverse, our context, India's context and profile is very specific and has a lot of different characteristics that specifically don't exist in a lot of other countries at the international level. We use that as a base and created an exhaustive list. And we included a lot of other things that are very important in the Indian public healthcare system, such as all our government health programs. We do have a lot of social aspects to when a healthcare provides a care to a patient, like occupational hazards, family history. COVID has become very important to as a part of our health history. So we put in all this context, and then we started building something that would act as the INPS, and we followed it up with a lot of consultation with different experts, essentially, since a person who's essentially eventually going to use this should be the one who should inform what is being developed. So we did various consultations with doctors, labs, medical personnel, frontline health workers, etc., and even private application teams of PHRs, HMISs, etc., so that they also inform us in terms of the implementation scenario from a tech perspective. What are the feasibilities? What are the gaps, or what are the constraints that would come in when this probably goes on ground? And finally, we combined it with the existing health infrastructure, the e-health infrastructure that exists, our ABDM profiles, so that whatever we are creating at a international level for India can be used within state, can be used cross state as well as at an international level. It is not something that only goes cross border. So followed by that, now what we have right now is a logical structure and a data set of FHR bundle, which is essentially how the IPS format will be implemented in a technical format. So this is what we have right now. It's FHIR bundle containing multiple entries and all these profile essentially. So there are two set of constraints. What we have right now in the overall IPS profile first follows the constraint of international patient summary, the guidelines and the structure that's followed there. And the second set of constraint is the ABDM constraint, the profiles that come under ABDM. So this ensures, as I said, that whatever is being created is interoperable within the country as cross border structure. So yeah, and now I'll take you through what we have currently. This is the current composition, where we have certain elements which just talk about the document information as to who the patient is, who's the author, who's sort of verified this information. Very important to validate what is being presented as a summary document by a system. And then it moves on to certain sections within the composition. What we had initially generated was three types of labels. One would be the required or the mandatory ones, which right now what we have are the allergies, intolerances, medication summary, and problems. The recommended ones, these are the labels if this information exists within the health record that is being summarized, that has to be pulled in and put into the summary document, which now consists of immunization, history of procedures, medical devices and results, and optional fields. So basis the situation, like Devika mentioned, that in a scenario of maybe visa approval, a lot of these labels will be important and a lot of these won't be. Similarly, in the situation where a patient is just being considered for his critical health condition, a lot of this information can be skipped because we have to find a balance between essential information and also keeping it small enough that it can be still called a summary. It doesn't become a whole health record, which again causes a lot of time utilization at the doctor's end or at the user's end, right? What we are moving towards, I'll also tell you, is that this is something that we had devised initially in our draft one. We are slowly also trying to create a structure or just a process where instead of having a required, recommended, or optional fields, we just make it three out of these many fields. So basis how much information is available from the health records, the creation of summary is not hampered. So if in case a allergy or intolerance is something that's not available, that should not hamper the creation of a summary or not stop the creation of a summary. So rather, if there are more important information from the other labels that are available, and that just fulfills like maybe a number of 3 or a number of 4, then that can also allow the system to create this. Now I'll take you through the detail of these labels very quickly. If you can see the first three labels that are mentioned in yellow, so I did mention that we did a lot of context study. We did a lot of what is required at an India level that is not present at the IPS level right now. So we added a few labels such as the advanced directives, alerts, and functional status. These would essentially cover things like what are the patient instructions at the time of healthcare when maybe the patient is not available or awake enough to convey those instructions, or maybe organ donation related directives that the patient might have left through. So these kind of information become very critical at various points where this is not available to the people around that are helping that patient. The second is alert. With the rise of people recognizing a lot of mental health issues, a lot of triggers and warnings that come with different diseases, these again become very important, especially in emergency scenario where a health worker might not be really understanding of very important triggers for a patient, and that might result in even worse situation than what they are dealing with at that time. So again, this becomes very important and critical information. And functional status. So functional status essentially tells about the physical and the mental cognitive ability of the patient, whether that currently is at a good stage, does not exist, etc. So these were some very few new labels that we sort of tried to introduce to make it holistic in nature. Apart from that, we are trying to cover general clinical problems. We are trying to cover history of procedures, medical devices that again become very important in case of especially patients who have undergone surgery. We also have a lot of wellness data that comes in right now that can become very important in just monitoring certain conditional patients, right? So then that is something that we are trying to capture. I want to just focus a little bit here. I know from a doctor's perspective, what went in the previous slides are very important, and they are essentially what most of our health records in general contain. But we've also tried to focus equally on non like on social aspects of it as well, where a patient story is also captured, if it is captured at by a doctor or a health service, any personal wellness notes, if there is a social history of alcohol, drug, tobacco abuse, any specific medication addiction. We are also trying to right now we are in the middle of finalizing whether vital should be a very important and something that goes at the top, right? Because when you think about emergency situation, a lot of this information is something that they capture immediately without even doing their maybe first aid at sometimes. So I wanted to just focus on certain things that we have tried to capture every edge case. What we are trying to do is that even if it is a case of maybe some social services related, situation, this kind of information would be probably a lot more important than a surgery or a procedure that happened. So IPS summary should not be very limited to just that very specific doctoral aspect of it, but also have that application in these edge cases. Moving forward, so what we have done currently is that with NRCS, we have released the draft one, which is undergoing consultation right now. We are trying to do the consultation with different users, different experts, so that what comes out at the end is something that is usable by every entity and every imaginable scenario that a IPS could be. We are speaking to general doctors, we are speaking to expert doctors, different patient facing applications on how they'll sort of portray to users, different health workers, laboratory teams, because labs again generate a lot of health data. It's like at least 10, 20, 30 pages of data that in most cases a doctor will not have the time to peruse through that properly, right? So then this becomes a very important use case just for that particular situation as well. And basis some of the consultations, some very important feedback has come through. Just wanted to share that so that you know how open we are to changing the whole structures format right now. We did think of adding blood group as it becomes very critical in emergency. Again, as I mentioned, removing the necessity of fields being mandatory, optional, etc., to create a summary document. Also, since we have added advanced directives, which are a lot more legal, which comes with a lot more, which are a lot more consent driven, not just a medical record that exists out there that can be summarized. So we also taking into consideration these complications that come with different kind of information that we're trying to incorporate within this. Again, now when we imbibe this INPS essentially with ABDM, how we are envisioning the different roles and responsibility are as follows. So we have a patient essentially in most of these scenarios that will own the consent, and essentially in most of the cases we are seeing the patient to be the person who essentially says that okay, I need the IPS to be generated for me for these particular records. So the initiator of the creation of summary in most of the cases, not all, of course, it's not exhaustive. We have the patient facing applications who are made in most of our or at least our first use cases, where they'll be aggregating these longitudinal records, creating the IPS and sharing them with the health information systems. HMIS at their end will also generate IPS and also consume IPS to show it to different users at their end. And then connectors who can build on just selling this as a system that different entities within the ecosystem can use. Now I'll just zoom out again and see that once this is implemented and this is functioning even at an interstate level, what are the different values that can be derived through the applications? We'll have a lot of policy preparedness. We talk about preventive healthcare. What this will enable is it'll give policymakers high quality anonymized data, and it'll also enable a lot of predictive analysis. So we'll move a step further to our preventive healthcare journey. Again, it safeguards a lot of cross border travel, not just for pilgrims, not just for any specific users, for any person, even as an individual who's traveling to some other country. It does safeguard him where he's in an unfamiliar jurisdiction. It'll also streamline and also encourage a lot of medical tourism, that currently sort of has a lot of problem in terms of documents data is carried manually, it is not readable, a lot of the terminology changes from one country to the other, a lot of medication changes. So it makes for a new doctor in a new country to very easily understand the health history of a patient who's come from some other country. And the next one is essentially, if you look again from a more zoomed out lens, the presence of this will also foster a lot of international health data packs, because it'll unlock a lot of services, a lot of trust building that happens from that perspective. And then overall support global healthcare workforce mobility. We do have a lot of situations where doctors are moved between countries, where there are a lot of onboarding delays, and also a lot of understaffed regions. So again, this will act as something that gives in quick and fast information to deal with such situations. Devika, if you want to come in, please, if I've missed out on anything that you want to add.
Thank you, Jaswini. So essentially, I think just wanted to give a quick vision of what we're imagining. And of course, some of the value-based applications have been listed by my colleague, and we truly want this to become as usable as possible and not just, again, another standard that exists, but is not actually being used in transactions, which is why I know Jaswini mentioned that, instead of having defined mandatory fields, we probably keep that to a very small, maybe a one or two fields which are mandatory, and actually put in other sort of measures in place or rules in place, which basically will classify the category or quality of the IPS. So maybe, the basic minimum requirement could be that we need at least two or three fields to be populated to actually qualify as the most basic form of IPS, while not defining what those fields are, so that we're as flexible to all sorts of use cases that can come up. And this is a feedback that we did receive, and we're also like trying to evaluate this as seriously. So, like my colleague mentioned, we're in the stage of getting a lot more feedback and doing a lot of consultations in any organized, formal way. So, if you have a way in which you would want to contribute um, to this work overall, we would be happy to receive that feedback. Currently we're sort of in this foundational work stage, where essentially we have worked with our national resource center to come up with the first draft, and we're going through consultations, and we've prioritized a few, and now the finalized version of the IPS post the consultations will be published properly, and then we will look at developing use cases at an NHA level, as well as trying to socialize this a lot more for ecosystem partners to also sort of come up with use cases, use this structure in ways that is beneficial for delivering healthcare, as well as just their entire processes that they might be doing. So yeah, just in case any of the audience members, of course, have questions, we'll be happy to take them. But if you're able to also maybe scan this QR and submit any feedback or expression of interest to collaborate with us, or give us any detailed feedback, or need more information on this, we'd be happy to do that. And we'd also ask the organizers to maybe after the session be able to share a link to the draft for those who are interested. We could do that as well. So yes, I think that's all from our side. We would pause here and hand it over to Jay or Cha to actually take us through the questions if there are any. And thank you for patiently listening to everything that we had to say. And over to you.
Thank you, Devika and Ojaswini. It's a brilliant presentation, like very nicely summed up a whole lot of things. I would request one of you to also paste the link to the draft in the chat. You could do that. Um, I think we can open up the floor for, we have 8 minutes, so let's open the floor for questions. It's very interesting that, like, usually how typically elsewhere IPS is used, but in this context, like how it could be used within the country, and then for the needs, like of course, like India itself, like we can consider as multiple countries put together because of the scale as well as the geography, and then the variety of needs that arises. But I think let's take the question from the audience, and then let's have the link in the chat if it is not there. Char, like, can we actually quickly go through the question, at least one uh, per person? Like, I
Yes,
think we already have. So could you
yes,
quickly read out?
yes. We have some questions from Dr. Vijayan Raghavan. So his first question is, I am based in Malaysia. If I am considering India for a procedure like a health screening or surgery, can I create an ABHA ID as a foreign national?
Currently, the Abha ID is only tied to the Aadhaar, essentially, which is the unique identifier for Indian citizens. And which basically means that if you're sort of have an Aadhaar, which is a unique identifier, sort of works like a social security number in a certain sense for India. Only then can you create an Aadhaar, because that's how it's verified. Um, but there is also provision, which is the Aadhaar address, which could be created without Aadhaar KYC. So it would basically mean that you have created a ID which is not Aadhaar KYC'd, which anybody could do from a PHR application. But I think for all usable intents and purposes, um, it won't be usable for you until you have an Indian Aadhaar. Yeah, so I hope that covers it.
Sure. We also
Yes.
have a question from Chaminda Sri Lanka that also connects with the GPS of SNOMED. Maybe that question also we can take.
A question from Dr. Chaminda reads, what was the effort needed to identify and contextualize the terminologies used for the INPS? How aligned it with the SNOMED GPS used in IPS?
Yeah, so essentially all those standards that so NRCS is the body that is responsible for also publishing the fire standards in India, as well as SNOMED CT adapted versions. So IPS is aligned to those standards, and it actually uses all of that, the standards of SNOMED CT, etc., within the relevant categories. So yes, it is aligned, to answer your question.
Thank you, Ms. Devika. We have a question from Sir Nitin. For countries in the global south interested in ABDM style models, what works as is from India and what needs to be redesigned for smaller or different health systems?
So I think what ends up, I think somewhat, it would be, that's why I covered the tech stack of ABDM as well, actually, so that people from other countries also have the context of that. I think what would be important to evaluate is how health records are being created. What are the standards that you are currently using in those specific countries, right? And for us, what actually became part of our process was to see that given the ABDM constraints, could be say that we have to have an Aadhaar ID to which it is linked, or could be that there is a proper health facility ID to which those records are linked, or even the use cases, specific social context like social history included in the INPS structure. Those were very intentionally incorporated into the IPS structure that we did end up coming up with. So I think what would be important to see is how digital health records are currently being created in the country. What are the guardrails around those, whether there are registries or some specific non-negotiables that are verifiable to some extent. And if they're using regular standards like fire, then I think this would be quite replicable in a certain sense. But also adapting it to the country's context and how the entities are actually exchanging data, how that DPI is envisioned, because it depends from country to country how they are doing it. But of course, since IPS is an international standard, it does have very clearly defined contours. So those can be largely applicable wherever possible.
The question from Sir Keith reads, can you explain the use case I saw where an IPS is generated after a procedure? Would it be an update of the IPS resource that was used at the beginning of the procedure, or just the details of the procedure to be merged in?
Thank you for the question. I think this is something that we were thinking about earlier. So IPS, okay, so there could be different entities that initiate the creation of the IPS. The example that we gave in the surgery case could be for a specific instance. So, for example, if the health solution provider, health HMI system used by the facility, is trying to use this IPS structure, and that's the use case they have envisioned, to create a summary of that of an inpatient procedure, could be lasting over a few days and might have multiple health records linked to it, that would become a IPS record individually, and that might be different from a patient initiated summary record that can be stored on the PHR application. So of course it becomes temporal. So for example, today if I'm a patient and I have a IPS record created, it would only sort of detail all the or capture all the past records that may have been created for me, right? And that would be the summary that I have currently, which I have created and stored in my application, and maybe has some self-reported data. If there is an emergency, I as a patient would actually share that IPS with the hospital, and they at the end of it might create a separate IPS, depending on the use case, right, or the usage of it. In future, the patient may choose to append this data to their current IPS and make it a lot more exhaustive, change the time period for which the summary structure is generated. Depends on the use case. But we also thought of maybe a concept of summary of summaries, that if there are summaries generated at multiple touch points, how can we create an overarching summary? However, we've kept it a little more open right now to actually see how the ecosystem ends up using it, and some insights from the ground, once it's actually rolled out, would define how we think about it in future. For now, we've allowed for multiple summaries to be created depending on the use case.
So for the question from Dr. Alvin, it reads, for the connectors and ecosystem, are they only a pass-through of encrypted messages, or are they allowed to decrypt some fields for transmission purposes?
I think how a connector would end up working, connectors again would be used by the software provider that owns the data to actually owns the data, or not owns, but creates the data. So if I'm a health management information solution and I want to generate a summary and I'm using a connector, then I guess there will be some level of whitelisting that is done at that point of time to actually be using that connector. So whatever decryption is sort of involved in generating the IPS summary, for from an ABDM perspective, that summary would be generated by the HMIS solution, right? Which means that it would be the HMI solution would be the entity that is recognized to even generate the IPS. So the connector would only be sort of relevant in the native context. It won't work independently. It would be a service used by the HMIs to generate the summary. But for our purpose, it has to be the HMIS that is generating the summary. So whatever decryption may be linked to that can happen, since the original data is also stored with the HMIS, of course, given that it's not exploited in any way and those safety privacy concerns are taken care of, for which the HMIS would have to take responsibility.
Thank you, Devika and Ojaswini. We have reached the top of the hour, and it's very interesting that, not only that, you could share very comprehensively, but also we took a lot of questions. I think there are a lot more, but we will collate all them and then send it over to you by email, and then so we can have the answers from you both, and then which can be relayed to those who are asked the question, and then for those who had asked for whether that will be the recording will be available. Yes, usually within 10 days, the recording of the webinar will be available in our YouTube channel. We are AeHIN, so you could actually, those who couldn't join in the beginning can always listen to that probably in a week or 10 days from now. With that, I will hand over to Cha back to have a group photograph.
Thank you, everyone.